Hi, my name is Kaley Binford, and my project is improving early identification of perinatal anxiety through utilization of a specialized screening tool. Committee. My DNP chairperson is Dr. Sabrina Condon. My Nursing 705 faculty member is Dr. Boniface Stegman. And my community member for this project was Jennifer Jackman, an MSN educated nurse. Background and significance. Perinatal anxiety is frequently underdiagnosed or inadequately treated, often dismissed as a typical part of pregnancy. However, it poses a significant concern due to its association with detrimental and serious health consequences. This scholarly project aims to evaluate the effectiveness of the Perinatal Anxiety Screening Scale, or PASS, in comparison to generalized anxiety screening tools for early and accurate identification of perinatal anxiety. Despite its specificity and potential benefits, the PASS remains underutilized, largely due to limited awareness, leading to decreased diagnostic accuracy, limited data tracking, and deficiencies in care. Review of literature. Anxiety can be caused by maternal factors such as feeling overwhelmed by the immense physical, social, and relationship changes, as well as uncertainties of pregnancy and fear of childbirth. Research has found that maternal anxiety during pregnancy can increase the risk of adverse effects for the mother, fetus, newborn, older child, and family unit. These risks include, but are not limited to, miscarriage, preeclampsia, preterm labor, unplanned cesarean section, postpartum hemorrhage, and postpartum depression. The lack of a universal screening process or tools for perinatal anxiety has caused an unacceptable number of misdiagnoses and undertreatment. Some women may be reluctant to seek treatment due to the still present stigma of mental health issues and treatment. They may also feel that juggling work and additional mental health medical appointment exemplifies anxiety and uncertainty in their lives. Other maternal barriers to appropriate screening and treatment of mental health issues includes lack of a robust support system, cultural beliefs, low completion of education, low socioeconomic status, and a lack of adequate health insurance. From the perspective of a medical professional, barriers can include patient refusal to participate in the screening process, treatment noncompliance, a lack of universal screening process for perinatal anxiety, and failure to follow up or initiate a referral after a positive screening. These issues require effective management to minimize barriers from the healthcare standpoint. Theoretical framework. This DNP project is most represented by Lewin's force field analysis. Lewin's force field analysis is an organizational theory of change. It is a tool for root cause analysis and is based on a state of equilibrium influenced by forces for or against the current situation or state. Counterbalancing the negative or opposing forces by increasing the positive or favorable forces helps promote change by reinforcing desirable effects and reducing the restraining factors. The force field analysis procedure defines the problem and the change objective. It then identifies the driving and restraining forces and ends with developing a comprehensive change strategy. The key elements of the force field analysis fit this DNP project by promoting change through the reduction of restraining forces and increasing of positive forces. Methods and design. This quality improvement initiative involves a retrospective review of electronic medical records, EMRs, from a women's services obstetric or OB clinic in southeast Kansas. The study focused on pregnant women aged 18 to 34 with the minimum necessary data collected from a total of 154 EMRs. So 77 from the pre-intervention period and 77 from the post-intervention period. Inclusion and exclusion processes were utilized to ensure records met eligibility criteria. The project specifically evaluated the use of the Perinatal Anxiety Screening Scale in identifying perinatal anxiety. EMRs were reviewed to assess perinatal anxiety identification, PASS scores, advanced practice provider follow-ups, and initiation of referrals for outpatient mental health services. The goal was to determine whether the implementation of a universal perinatal anxiety screening protocol utilizing a specialized screening tool improved early and accurate identification, supported initiation of appropriate interventions, and improved patient outcomes. The sample. So the EMR requirements for study inclusion included the patient had to be between the ages of 18 and 34. The patient had to be a biological female with a functional uterus, be pregnant during the time-specific data collection. The patient must have received prenatal care at the project site obstetric clinic. The patient agreed to be assessed utilizing the Perinatal Anxiety Screening Scale. The post-intervention EMR had to be from within the study dates of December of 2024 to May of 2025. And then the pre-intervention EMR had to be within the last year prior to the implementation of the project intervention. Data analysis. The use of quantitative data was used to evaluate if implementation of the PASS increased the rates of perinatal anxiety identification as compared to pre-intervention rates. A priori analysis was completed, resulting in the suggested sample size of at least 156 EMRs. Descriptive statistics provide a concise summary of the characteristics of a dataset. It is often used to describe the participants of the study. Descriptive statistics were used to assess whether the screening results were considered positive or negative in the participants that met inclusion criteria for pre- and post-implementation of the intervention. The data collected to evaluate the effectiveness of the PASS in identifying perinatal anxiety was analyzed using the chi-square test with a confidence interval with significant evidence to show a change in one direction. The chi-square test is used to analyze categorical data for the determination of statistically significant differences between each group for pre- and post-implementation of the PASS. An upper tail z-test for the difference of two proportions was used to determine if there was a statistically significant difference between the pre- and post-intervention groups. Results. There was a statistical significance between the pre- and post-intervention implementation groups. The pre-implementation intervention sample consisted of 0% with scores that indicated positive results and 100% of no screening performed. The post-implementation intervention sample consisted of 16.25% with scores that indicated positive results and 83.75% with scores that did not meet the cutoff score to be considered positive. The chi-square test and the upper tail z-test for the difference of two proportions revealed that the pre-intervention group did not complete the PASS and had significantly lower rates of perinatal anxiety identification at 0 than participants in the intervention group who completed the PASS with 16.25%. Limitations. There were some limitations to this project. The design was time constrained, which prevented opportunities for intervention, implementation, and data collection throughout the full pregnancy term of participants. This limitation reduced the likelihood that individual participants who scored positive on the PASS would have their subsequent screenings tracked for mental health intervention effectiveness. A second limitation involved the PASS being administered on paper for the participant to complete before their scheduled OB appointment. Due to the short window for study implementation, an electronic PASS form was not created within the online healthcare portal for participants to complete prior to their scheduled appointments. This limitation may have impacted the results by not allowing participants to fully complete the screening or by pressuring the participant to mark choices hastily without careful consideration of each question. This limitation was deliberated before study initiation. However, as stated previously, an electronic pass form was not an option due to the time frame of the study. An additional limitation or barrier involved the unwillingness of the advanced practice providers providing care in the women's services clinic to initiate an outpatient mental health referral for patients who had positive pass scores. This barrier could be attributed to the preference of the advanced practice provider to treat perinatal anxiety through the clinic, or to a lack of awareness of the available outpatient services in the local area. Discussion. Prior to this study, the project site lacked a universal screening process for perinatal anxiety, highlighting the need for the specialized screening tool intervention to reduce adverse outcomes associated with this condition. The primary finding of this project demonstrated improved identification of perinatal anxiety in pregnant patients between the ages of 18 and 34 who received care at the specified study site after implementing the PASS. Although the observed change in perinatal anxiety identification in the post-intervention period demonstrates progress, a more extended time frame for data collection would potentially track treatment effectiveness related to advanced practice provider follow-ups on positive screenings and mental health outpatient referrals. In addition, a longer time frame would allow for PASS scores to be trended for the individual pregnant patient and possibly improve the treatment plan effectiveness. Implications for practice. Perinatal anxiety continues to be a significant concern due to detrimental and serious health consequences. Pregnant women are often not diagnosed with or treated for perinatal anxiety due to the misconception that anxiety is a normal occurrence. Generalized anxiety screening tools do not adequately assess for perinatal anxiety and often miss important indicators of this mental health concern. The Perinatal Anxiety Screening Scale has proven to be effective in the timely identification of perinatal anxiety. However, it is an underutilized tool due to a lack of awareness of the specialized screening tool. With the use of a validated screening tool such as the PASS, healthcare providers can identify perinatal anxiety, follow up appropriately, and refer to outpatient mental health services as warranted. Standardization of screening processes creates consistency and reduces gaps and deficiencies in care. This project identified pre-intervention inconsistency in the screening process and highlighted the post-intervention hesitancy to refer individuals with positive PASS scores to outpatient mental health services. In addition, the project revealed opportunities for the refinement of screening processes by disseminating the results and creating a pathway for clinical practice improvement. The project reinforced that utilizing specialized screening tools positively influences the timely and accurate identification of perinatal anxiety, supporting the evidence in the literature. This project contributes to vital future research on utilizing specialized screening tools such as the PASS as a successful strategy for identifying perinatal anxiety. This positive impact denotes significant progress towards reducing negative outcomes associated with perinatal anxiety. Additionally, the project highlights the need for future research on associations between specialized screening tool utilization and identification and subsequent treatment of perinatal anxiety. Conclusions. This project supported improved identification of perinatal anxiety through the utilization of the Perinatal Anxiety Screening Scale as a specialized screening tool. The results of this in-depth analysis demonstrate that improving perinatal anxiety identification is attainable and imperative to reducing associated adverse outcomes in the pregnant woman, fetus, newborn, older child, and family unit. The establishment of the specialized screening process resulted in progress towards the goal of timely and accurate identification of perinatal anxiety to allow for advanced practice provider follow-up and referral to outpatient mental health services as warranted. This impact supports the utilization of specialized screening tools, including the PASS. The recommendations for future research are to focus on identifying the most effective post-screening intervention strategies for reducing perinatal anxiety and exploring the relationships between early detection of perinatal anxiety and related health outcomes. Reflection. So the key points here are what would I have done differently and in the future, as well as the DNP program impact. So looking back at the journey that was this project, I would know how to be more prepared and know exactly what I needed to do regarding coursework, when I was creating the study, what to do exactly for that, and obtaining approval from all the parties, just what I needed to do for that and the entire process involved. As for the study itself, there's not much that I would change overall, especially not its intended purpose. I do plan to advocate for the continuation of utilizing the PASS in practice and appropriate treatment for perinatal anxiety. The pursuit of this educational goal of earning a DNP has been an extraordinary and very trying process at times. There were a lot of ups and downs along the way, but I had a strong support system, not only from my friends and family, but also from my DNP chairperson, Dr. Condon, my advisor, and my course instructors. I've recommended this program to several of my nursing peers, and I sincerely hope they see it for the opportunity that it is to expand their knowledge and expertise like I have. It's surreal that my time as a grad student is coming to an end. This program has already opened so many doors for me, and I will continue to be grateful for this journey. So to wrap up this presentation, I will show my reference slides without commentary, but thank you for taking the time to listen to my presentation, and I hope that you gained something from it. Thank you.